integrative medical biochemistry. Let me just make sure the camera is adjusted. Can you? The camera.
Okay.
Well, I'm not in the center.
This is fixed.
So it's fine. It's fine. Today's session is about disorders of lipoprotein metabolism. And I'm sure that you already know what lipoproteins are. You had a full lecture about lipoproteins. So initially, we're going to review it, and then we're going to link it to different disorders and syndromes. These are the objectives of today's session, where we're going to be talking about lipoproteins in general, but then we're going to talk about mainly about the association with coronary and peripheral vascular diseases. I know this is endocrine block, so you're going to ask me, well, this is cardiovascular. Well, it's not, because we're going to see that several conditions and diseases that are related to endocrine system basically will cause dyslipidemias. We're going to see which ones, and you have to try to identify these conditions because they will affect the lipoprotein concentrations. This is why it's linked to endocrine block as well. Also, we're going to just briefly touch upon the fact that people with hypertriglyceridemia, they have higher rate of acute pancreatitis. We'll talk about it. And then also we'll explain the role of disordered lipid metabolism in non-alcoholic fatty liver disease. And finally, we're going to describe in general the significance of dyslipidemia characterization. You need to know what's the cause, because this will change the treatment based on the cause of dyslipidemia. Now, if you want to review the lipoproteins just quickly, briefly, you can see that lipoproteins are basically the reason we have the lipoprotein in our circulation for what? Why do we have lipoproteins? Transport of lipids. Why? Because lipid what? Does it dissolve in water? Exactly. Hydrophobic. This is why this is the best way in terms of trying to transport it, because since it's hydrophobic, and we know that plasma is hydrophilic, water aqueous in nature, that's why they need to be transported as lipoproteins. In these lipoproteins, you can see that the core of the lipoprotein is composed of triglycerides and cholesterol ester, and 80% of the cholesterol in circulation is in the form of cholesterol esters. At the same time, the surface, you can see that it's covered with one layer of hydrophilic surface, and that includes the phospholipids. And in that phospholipids, you can see that the cholesterol is spanning that layer. At the same time, we do have protein components of lipoprotein, and this is the apolipoproteins. What's the function of apolipoproteins? They bind the receptor, retain the structure of the lipoprotein, and also activate enzymes such as lipoprotein lipase. So it has three different functions. Now, a few things. When I say LDL or HDL measurements, just want to make sure that you understand the concept here. You can see that the lipoproteins include multiple components of lipids. That includes cholesterol, includes phospholipids, triglyceride. So when we say, as a doctor, you're getting the profile, the lipid profile, you're getting LDL, HDL. Is that correct term that people are using? It's what? Cholesterol content of the lipoprotein. So when you say LDL-C or cholesterol, basically in that lab, they're measuring the cholesterol content of the lipoprotein. When you say HDL-cholesterol, we're talking about cholesterol content of HDL, the VLDL, because you can see it's a soup, right? It's multiple things, but in the lab, we measure the cholesterol content of LDL, HDL, VLDL, and so on, and this is what's being reported, not the apoproteins or the triglyceride. I mean, we can measure triglyceride as well, but this is what we refer to when we say when you see this lipid profile, we say LDL-C, cholesterol content in the LDL, and that's what's being measured in the lab. Are we clear about this? Now, why do we refer to it LDL, VLDL, HDL? It's all based on what? Density. Basically, if you take that plasma and spin it, of course, dense particles will go down faster than if it's lower density. And that's what we see. If you look into the chylomicron right there, you can see that they're larger in size because they're loaded with triglycerides. What's the percentage of your diet that is triglycerides? 90%. Your diet is all triglyceride. So that's why chylomicrons, which are made mostly actually it's in the intestine, they're loaded with triglyceride. Now they get transported to the circulation through the lymphatic system and so on. But if you look into the density, you can see that high density lipoproteins are the highest density. That's why they precipitate or they settle down faster if you were to spin that plasma sample. So based on this separation, when you separate the plasma, the HDL high density would settle down faster than the chylomicrons, which is lower density. Now, as we know that lipoproteins composed of several lipoproteins, that includes the chylomicrons, which are, as indicated, loaded with triglycerides. Then you have the very low density lipoproteins, and there are few apolipoproteins that I would like you to know, including the ApoB100, apoprotein 100, or ApoB. We'll see why. We have also intermediate density lipoprotein that's formed from the very low density lipoproteins. The very low density lipoprotein, which organ synthesizes the very low density lipoproteins? Liver mostly, and intestine. So as it's being transported into circulation, we have the lipoprotein lipase enzyme in the endothelial cells, the lining of the vessels, which hydrolyzes the triglyceride. So the size of that particle becomes smaller because basically there was hydrolysis of triglyceride taken by the tissue. As a result, the size becomes smaller. Then we do have the low density lipoproteins. These are the bad lipoproteins. And when we say bad, because if you look into the cholesterol in the LDL content, this is what we call the bad lipoprotein because it is atherogenic. And this is the most cholesterol rich of all lipoproteins. This is the LDLs. And it gets taken by the uptake is mediated by the ApoB100 and LDL receptors. The LDL receptor is present mostly where? Mostly in the liver, but it's also present in all tissues. So how do we deliver most of these lipoproteins or the content of lipoproteins to the tissue through what? The VLDL, mostly. Hydrolysis of triglycerides gets taken, but also there's uptake of cholesterol and other lipids, but then it becomes intermediate, then it becomes LDL, and then it goes back to the liver. But also, there are many tissues that also could take LDL because they do have the LDL receptor. And one cell that is really the one that's causing atherogenicity is what? What do you think? Macrophages. Macrophages have LDL receptor, and they do take the LDL. Not only they have the LDL receptor, they have also the scavenger receptor. And that scavenger receptor, what's different about it? That the LDL receptor doesn't take the oxidized LDL. Where do we get that oxidation? From oxidative stress. That oxidative stress is associated literally with any disease, cardiovascular disease or Endocrine disease, I mean, they have reactive oxygen species generation that cause oxidation of the lipids. Now, the oxidized LDL needs special receptor because the LDL receptor doesn't recognize the oxidized LDL. It recognizes both. The scavenger receptor recognizes both the LDL and the oxidized LDL. And I'll show you what the problem with the oxidized LDL, that it gets taken up by the scavenger receptor, but the efflux of this oxidized LDL or cholesterol is poor. And we'll talk about it. This is why there's accumulation of the macrophages, and these are precursors of atherosclerosis, as you will see. Then we have the high density lipoproteins, which initially synthesized by what? The HDL. Liver, and to some extent, there's some in the intestine. Now, when they're synthesized, they're cholesterol free. But what do? They get into circulation, release into circulation, and they start collecting cholesterol and sending it back to the liver and other tissues, such as, which tissue you think would utilize cholesterol mostly? What about steroid synthesizing tissue, right? Because steroids are all the precursor of steroid what? Cholesterol, right? So cholesterol, most of these tissues, gonadal tissues and other tissues that synthesize steroids we could take HDL through the HDL receptor. Now, I'm not sure whether you've been introduced to lipoprotein A. Do you know what's lipoprotein A? It's something like a hot thing right now. I'm sure you heard about the lipoprotein B, 148. What is this lipoprotein A? We're going to describe it more towards the end. We'll come back to this lipoprotein A when towards the end, because this is an atherogenic lipoprotein, and you'll see that it increases in many conditions. Hyperthyroidism and other conditions are associated with an increase in lipoprotein A, which is atherogenic, and we'll talk about the mechanism of the lipoprotein A later on, towards the end of the lecture. But you do need to know it because you can order it and you can measure it in the lab as well. So let's move on and let's look into the lipoprotein composition in the plasma. We have the chylomicrons, then we have the remnants. This is what's left over after we take a lot of triglyceride, cholesterol, phospholipids, and so on out of this chylomicron. It becomes chylomicron remnant. Then we have the VLDL, IDL, LDL, HDL. Don't worry about the subclasses of HDL, we just say HDL. Now the chylomicrons, look at the density. You can see that they have lower density as you go on from chylomicrons to the HDL, but also look into the main lipid components. We said chylomicrons loaded with mostly triglycerides. Where do we get these triglycerides from? The diet, because they're synthesized in the intestine. Now, the remnants, notice here that you got rid of a lot of triglycerides. So the percentage of triglycerides to the other phospholipids and cholesterol now is increasing or decreasing. What do you think? Percentage of triglyceride to phospholipids and cholesterol. It used to be, let's say 40 to 1. Now we're talking about 1 to 1. So it's decreasing. But look into the chylomicron remnants, we have the B48. The chylomicrons has the B48. Then if you look into the VLDL, we start seeing the B100. I do need you to know the B48, B100. Look into the LDL, the B100. And that's the apoprotein B100. If you go to the HDL, mostly we have the A1, A2, and A4. If you look into these lipoproteins, the major apolipoproteins of high density lipoprotein is the alpha lipoprotein, which is designated as A. You can see that it's mostly A1, A2, A4. If you go to major lipoprotein of LDL, it's called the beta lipoprotein, And this is B100, which is found in the VLDL and LDL as well, mostly LDL. If you look into the VLDL, it has B100, but it has other apolipoproteins. Do you think these lipoproteins are, once they're part of that lipoprotein, they don't get transported to other lipoproteins, or they're integral part that do not basically get lost? Some can be actually transferred from one lipoprotein to the other. Others, some are integral part, they don't. They stick with, if they're part of the chylomicrons, they stay there. They don't get transferred to another lipoprotein. So the chylomicrons contain also truncated form of ApoB. We're going to discuss this more as we get on with your study. How is it truncated? It is the same gene that synthesizes the B100. But this is what we call RNA editing, where there's a stop codon. Instead of synthesizing the B100, stop codon, now we're synthesizing B48. We'll talk about this RNA editing later on, not in this block. ApoE is found in the VLDL, HDL chylomicrons. You can see the ApoE right there. And we'll discuss the ApoE lipoprotein later on. Now, if you look into the apolipoproteins, we said the HDL, it contains what? Which lipoproteins? The A, designated as A. So you'll see the ApoA1, and this is why we said structure protein for HDL. You can see the ApoA2, structure protein for HDL. And if you look into the ApoB48, we said, and ApoB100, these are where? VLDL and LDL. Mostly the ApoB100, structure protein for VLDL, LDL, IDL. From the name, you could tell where it's located. And I need you to know the ApoB148 and the A1Y. We're going to look into the phenotypes of lipoproteinemias, and you'll see that these would come back. Now, we do have ApoC2. I'd like you to know ApoC2, which is coactivator for lipoprotein lipase, which is present where? In the endothelial cells of the lining of the vessels. And this is, they have the ApoC2. And we'll see what happens with deficiency of ApoC, which phenotype would be formed. ApoE is ligand for binding of LDL receptor. So if we have familial hypercholesterolemia, what happens with ApoE? It's a ligand, right? So it binds to the LDL receptor. So if the LDL receptor is not there, what happens? From the name, familial hypercholesterolemia.
There will be increased deposits of triglycerides in the body. This will cause eruptives and illness.
True. Let's look into major lipoprotein metabolism. This slide was given, I think you had it already before in Mol 125. First, we have the absorption pathway in the intestine. Now, we have the chylomicrons being synthesized in the exogenous pathway to the liver. In the liver would take the fats in the chylomicrons, synthesize the VLDL. The VLDL, this is the endogenous pathway through the LPL, lipoprotein lipase, which we said it's in the endothelial cells, would basically hydrolyze the triglycerides in the VLDL, and it becomes IDL and then LDL. Now the LDL, which deliver also, as I said, there's the LDL cholesterol, receptor, and also the cholesterol can be delivered to the cells. Now two enzymes come into play. This is the CETP and the ALCAT. The ALCAT, lecithin cholesterol acyl transferase. The CETP, cholesterol ester transfer protein. They do play a major role in what we refer to as reverse cholesterol uptake. They would form the HDL, and we'll talk about this in more detail next slide. So this is the reverse cholesterol transport pathway. What is the reverse cholesterol transport pathway? Why is it clinically related? We're going to talk about this in a minute. So if you look into cholesterol in the tissue, peripheral tissue, we said HDL is the good HDL. Why? Because the cholesterol, we want it to be in the HDL. We don't want it to be in the LDL. Why? Because we're reversing, we're taking back, we're transporting back the cholesterol back to other tissues, other than the peripheral tissues, that including the foam cells, including endothelial cells, muscle cells, smooth muscle cells. So we have cholesterol through an enzyme called LCAT, lecithin cholesterol acyltransferase, will take the cholesterol back to the lipoprotein, and then the lipoprotein basically with the cholesterol through an enzyme called the CETP. This enzyme is not illustrated clearly. This is the right one. Why am I saying this? Because you can see that the CETP takes the cholesterol back into the VLDL remnants and chylomicron remnants. And there are different drugs right now in the being tested, clinical trials, to try to block the CETP. To do what? To induce HDL. To increase HDL will basically reduce your atherogenicity, will reduce the percentage of heart attacks, strokes, and so on. And these are so many drugs right now in the market being tested, which they are ACETP inhibitors. But at least you understand why these two enzymes are involved in this reverse transport, cholesterol reverse transport. Why would we go for CETP inhibition? To induce HDL. Why? Because if this is blocked here, there's going to be more HDL. Do you see what I'm saying? So now, still, these are under investigation right now. So, which enzymes that are important for the lipid metabolism? Lipoprotein lipase, which we already described. This is activated by ApoC2, as we indicated before. And then you have the liver lipase, which again, the lipase, when we say lipoprotein lipase or liver lipase, it hydrolyzes the triacylglycerol, trig, in the liver, and it's activated by the ApoE lipoproteins. We have the LCAT and CETP. Now, receptors, we already indicated the LDL receptor. We're going to see what happens with the LDL receptor mutations. And this is a common mutation. We're talking about 1 every 500 people have this mutation of LDL receptor. So they end up with what? Familial hypercholesterolemia. Now, it is localized, the LDL receptor, predominantly at hepatocytes. When there is increased intake of cholesterol, this would downregulate LDL receptor in the liver. As a result, there is less uptake of the LDL. As a result, what happens to the LDL cholesterol? Increases. So when you have mutation of the LDL receptor in the liver, there is reduction of uptake of the LDL. As a result, the LDL cholesterol will be way, way high. I had a friend who's my manager when I joined Miller Fillmore Hospital. He had familial hypercholesterolemia. His cholesterol levels, I mean, his name was John Love. He was slim. He used to run every day 10 miles every day. And then even though his cholesterol, talking about LDL cholesterol, was 1,000. His parents, 3,000. I mean, it's really common. As I said, 1 every 500 people will have the LDL receptor mutation, and they will have familial hypercholesterolemia. It's genetic, and it does cause increased level of LDL cholesterol, and it actually, most people in the age of 40 to 50, they have heart attacks and strokes and so on. Now, we do have the HDL receptor, which is basically, as indicated, localized predominantly in cells that synthesize steroids. And then you have the scavenger receptors, which we said the main function of this receptor is uptake of LDL but also it takes oxidized LDL. And we're going to discuss this in more details. Yes. So,
We would like to make a video,
sure.
recording video while the online sessions.
Sure. So let's talk about disturbances of lipid metabolism. The first disturbances, you're going to look into essential, but I'm sorry, you're not going to video.
No.
Okay, because you have to take their permission if you're going to do that. So there are several disturbances of lipid metabolism. That includes essential types of disturbances. And then we have secondary types. We're going to discuss both. The first essential types of disturbances include the hyperlipoproteinemias, hypo, and then dyslipidemia. What's the difference? When I say hyperlipoproteinemias, hypo, and then dyslipidemias, have you thought about the differences between hypo, and dys? What's the difference between dyslipidemias, hyper or hyperlipoproteinemias? Any idea? From hyper high, hypo low, but it's related to what? Lipoproteins. What about dyslipidemias? Could be triglyceride, could be cholesterol. These are not lipoproteins. Could be up or down. It's this. Lipoproteinemias. Basically, it could be any of the lipids. That's abnormal in circulation. Are we clear about this? Now, how do we classify these hyperlipoproteinemias? There are different classifications. It depends on the textbook that you would read or look at. And I'm going to give you at least 2 classifications, but you might find more of these classifications. Why do we need to know it? Because you're going to see type 4, type 1, type 2. At least you understand the language. You understand as a physician what is meant by type 2 hyperlipoproteinemia, for instance, or type 1, 2, 3. What's the phenotypes? So this is where we introduce to you the Fredrickson classification of hyperlipoproteinemias. Are you aware of the Fredrickson? You haven't had it. Okay. This is the most common classification of hyperlipoproteinemias. And here they classified the phenotypes of hyperlipoproteinemias into 6 types: the 1, 2A, 2B, 3, 4, and 5. And each phenotype basically is characteristics of the levels of different lipoproteins. So if you look into phenotype 1, if you look into the lipoprotein elevated, that includes the chylomicrons in type 1, but also chylomicrons are increased in type 5. Look into triglycerides. Is it increased in all the phenotypes? No, it's only in type 1, type 5, and to some extent type 3 and 4. Why is that? From the name, chylomicrons, they're loaded with what? Triglycerides, right? As a result, we have high triglycerides in type 1 and type 5.
Thank you.
No problem, thank you. So why do we need to know that? Because these people with phenotype 1 and 5, they have higher chance of developing what? Acute pancreatitis. And this is the 3rd common cause of acute pancreatitis, which is hypertriglyceridemia. Okay? At the same time, if you look into atherogenesis, in coronary atherosclerosis or peripheral atherosclerosis, you'll find 3 types. That includes type 2A, 2B, 3, and these are associated most likely with which lipoproteins? LDL cholesterol. So if you look into type 2A, 2B3, you'll find the LDL cholesterol increase mostly in 2A, 2B, but to some extent in type 3, you'll see that there is increased atherogenicity for other reasons. But you'll see that it's 2A, 2B, mostly with LDL cholesterol being increased, and this is associated with atherosclerosis. Okay, so we do have different molecular defects. As you can see, we'll discuss this in more detail as we get on with the lecture. You can see that in type 1, even though we place the LPL and ApoC2 as deficiency associated with phenotype 1, actually the LPL is more characteristic of phenotype 1. ApoC2, which is co-activator of the LPL, we said, is more towards the phenotype 5, as you will see in the next few slides. So this is what we call Fredrickson classification of hyperlipoproteinemias. So what are the types of, main types of hyperlipoproteinemias? We do have primary, we have secondary. Primary, mostly genetics, but could be polygenic. And you can see that the primary, the first one, which is the familial combined hyperlipoproteinemias. This is the most frequent genetic hyperlipoproteinemia and manifests mostly likely in phenotypes 2A, 2B, 5. What are the characteristics of 2A, 2B? We said atherogenicity, high atherosclerosis. So these people who have the familiar combined hyperlipoproteinemias, they're at higher risk of heart attacks and strokes because they have the phenotype, Fredrickson phenotype, 2A, 2B. But also they're at higher risk of what? Sometimes the phenotype here, 5, we said it's usually associated with what? Lipoprotein, high lipoprotein, which one is going to be high? Chylomicrons, 5. And we said triglycerides, and that is acute pancreatitis. This is where you're going to start seeing a lot of textbooks where you say phenotype 2A, 2B, at least you understand what's this classification. Now, the mechanisms involved basically in the primary familiar combined hyperlipoproteinemia is increased secretion of VLDL by the liver. As a result, we do have the, as a result of this genetic predisposition and could be acquired due to environmental factors. Now we move on. Familiar hypercholesterolemia, which I just indicated. I told you before, what's familiar hypercholesterolemia? It's associated with what? LDL receptor being basically mutated. So when there's mutation of LDL receptor, this will lead to decreased uptake of LDL, increased concentration of LDL cholesterol. I mean, this is more, I should write it dash cholesterol. And the incidence is 1 every 500. So every 500 patients you see will have familial hypercholesterolemia. It's common. Now, but because of the fact that it is predominantly manifested by as phenotype 2A, so you'd see that people with high LDL cholesterol, they will have what? High atherogenicity. The next one is polygenic hypercholesterolemia, which is the most frequent hypercholesterolemia, and it's type 2A. The minute I say type 2A, think of atherosclerosis. By the way, 2A, 2B we said, and 3 is also associated. These are the mechanisms of development that include genetic predispositions. I listed some of it for you. And environmental factors such as alcohol, diabetes mellitus, or type 2 diabetes, increased intake of carbohydrates and lipids will lead to a phenotype that is type 2A, and this is polygenic. When we say polygenic, multiple genes, multiple factors rather than one gene. Then we go to familiar dyslipoproteinemias. Again, familiar dyslipoproteinemias. And this is, there's increased xanthomatosis and acceleration of atherosclerosis, and this is type 3. And we said type 2A, 2B, and 3 are associated with atherosclerosis. This one is associated with type 3 phenotype. We have hypertriacylglycerol, which is quite frequent disorder, and it is an inherited disorder. We have familiar defect of lipoprotein lipase and ApoC2. Lipoprotein lipase, when we have deficiency, which phenotype? Told you, LPL, lipoprotein lipase, and ApoC. When I said the ApoC2 should be phenotype 5, the lipoprotein LPL should be type 1. So this basically manifested by phenotype 1 with defect of LPL, and also phenotype 5 when defect of ApoC2, which is coactivator of the LPL. So ApoC2 is a coactivator of LPL, lipoprotein lipase. Finally, the familiar alpha lipoproteinemias. We said the alpha apoproteins are present where? In HDL. So when we have the familiar alpha lipoproteinemias, there's increased concentration of HDL cholesterol in the blood. Thus, there's a reduction of atherosclerosis. Okay, we move on to the secondary. When I said, why are we being given this lecture in endocrine? Well, look into the secondary conditions that could lead to hyperlipoproteinemias or dyslipoproteinemias. That includes diabetes, hypothyroidism, nephrotic syndrome, chronic renal failure, primary biliary cirrhosis, chronic alcoholism, some drugs such as contraceptives, estrogens, and so on. So this is a list of conditions that are associated with different dyslipoproteinemias, such as, if you see the LDL, cholesterol, again, LDL, always think of it, LDL cholesterol, elevated in hypothyroidism. But also, if you look into hypothyroidism, we have increased IDL, but IDL, we don't usually measure it in the lab. You just get the LDL, HDL, triglycerides, and total cholesterol. If you look into lipoprotein A, which we're going to describe in a minute, is increased in hypothyroidism. It's right there. So what does this tell you? When LPA, when we said lipoprotein A is what? It's atherogenic lipoprotein. And we'll say why in a minute. So in hypothyroidism, when your LDL is elevated and IDL elevated, this is usually associated with increase of lipoprotein A. There's increase in atherogenicity. You have also Cushing's syndrome, Gaucher syndrome, let's see which one, type 2 diabetes. You'll see reduced, what? It's increased with LDL, type 2 diabetes usually. HDL is lower in type 2 diabetes. VLDL is elevated. There's no indication of, in terms of changes in lipoprotein A. You have other conditions here. You can see it. I'm not going to go through it, but this is just tells you what each condition is going to be associated with. Increase, decrease of LDL. You can pick and choose, especially to see that it is associated with dyslipoproteinemia. Notice here, the hyperthyroidism is associated with what? Reduced LDL. Hypo is associated with increased LDL. So at least this tells you that if you have someone with hyper or hypothyroidism, what to expect in terms of his lipid profile to be. Okay, another classification. As I said, I'm going to give you two classifications. One quick classification, which would help you in terms of to know what's the lipid profile associated with each condition. That classification is basically classifies the disorders into three categories. The first one, primary disorders with elevated ApoB containing lipoproteins. Then we have the inherited causes of low levels of ApoB containing lipoproteins. And finally, the genetic disorders of HDL metabolism. The first classification, need to speed it up, includes lipid disorders associated with elevated LDL cholesterol and normal triglycerides. Then we have elevated plasma levels of lipoprotein A. Thirdly, lipid disorders associated with elevated triglycerides. Genetic disorders with a low or high HDL, basically these are all inherited causes of hyperlipoproteinemias. These are the conditions associated with elevated LDL. Come on, I cannot see this. With LDL cholesterol, normal triglycerides. You can see, oh, you can see them now. So you have the LDL cholesterol, but normal triglyceride. That includes familial hypercholesterolemia, which is the same one we just described in the first classification. Just this is different classification. But at least you remember that this is high LDL cholesterol, normal triglycerides. That's how you think of it. If you look into familiar defective ApoB100, the same, LDL cholesterol is elevated, normal triglycerides. We have another one, which is the autosomal dominant hypercholesterolemia, which is due to mutations in the gene for PCSK9. And for this one, the PCSK9 determines basically the number of low-density lipoprotein receptors. We have other ones. This is just general description. I'm not going to hold you for this classification, but I do require you to know at least the first classification, because that's the most commonly used one. But I wanted to show you examples of other classifications. Oops. So we said here we have this one. Now, just since we've been talking about the xanthomas, we have the tendon xanthoma, tuberous xanthoma, and you know what these xanthomas are, right? So I'll skip this one. Lipoprotein A. Abnormal lipoprotein A, we said it's atherogenic. What do we mean by this? There's a lot of, several studies linked lipoprotein A with atherogenicity, high risk of developing heart attack and strokes. What is lipoprotein A? Well, here's the thing. Well, if you look into the lipoprotein A, this is an example of lipoprotein A, just right there. You can see that the nucleus of lipoprotein A is LDL. But through the ApoB100, it's linked through disulfide linked to different groups, and these what we refer to as Kringle. There are 5 different Kringle domains. One of these Kringle domains has around 75 to 85% similarity to plasminogen. Does plasminogen ring a bell? Plasminogen gets split into plasmin. And what does plasmin do? Fibrinolytic active. It breaks down blood clot, small ones, right? So what happens? This Kringle, lipoprotein A, competitively inhibits the plasminogen activation. How? It basically, notice here that plasminogen is activated by plasminogen activator, TPA. Now, this one binds to the TPA, the lipoprotein A. As a result, plasminogen is not activated to plasmin. This is why it is pro-atherogenic. Now, finally, the lipid disorders associated with elevated triglycerides includes familial chylomicronemias syndrome, ApoAV deficiency. This was discovered in 2005. And then we have the GPI-HBP1 deficiency, which is an endothelial cell protein that binds to the lipoprotein lipase and chylomicrons. We have other conditions associated with it. I'll leave it up to you to read it. We have the genetic disorders of HDL metabolism, and we said it could be increased or decreased. One of it is the Tangier disease. Do you know what's the function of Tangier? Why do we have the Tangier disease? Did you come across Tangier disease? Okay, Tangier disease, basically condition where there's almost absence of HDL. There's no HDL. The reason for that, because we have a transporter called ABCA1, ATP binding cassettes, A1 transporter, which is responsible for the efflux, taking the cholesterol out of the cell. And we're going to see how it plays a major role in atherosclerosis. This is the ABCA1 transporter. And then we have the inherited causes of high levels of HDL cholesterol. That includes the CETP deficiency. When you have CETP deficiency, what happens to the cholesterol? What did we say about CETP inhibitors right now? HDL goes up. So these people with CETP deficiency have higher HDL. As a result, they're protected from atherosclerosis, heart attacks, strokes, and so on. So it's a good thing. Okay, just quickly go through this slide. And you can see here that we have macrophages. This is the macrophage. And in this macrophages, you can see that we have the scavenger receptor A, which we said it could take what? LDL and oxidized LDL. Takes it up. Basically, that's where cholesterol is being delivered to the macrophage. And this macrophage, this cholesterol normally gets pumped out through the ABCA1 transporter. However, this export is limited. As a result, there's accumulation of cholesterol. Now, seeing is believing. What you're looking at, actually, these slides were taken from Russell Ross. He's a great scientist. I met several times, and he gave me these slides. And these are slides taken from monkeys that were given high-fat diet. Russell Ross is the first one to call atherosclerosis as being an inflammatory condition. So these are slides actually transmission microscopes. You can see the endothelial cells lining of vessels. Now, he started feeding these monkeys high-fat diet. Look into the monocytes, basically taking that cholesterol and the fat into them, and now we can see them penetrating the endothelial cells. You can see some beginning of the plaques formation. This is ruptured plaque. After some time, the plaque ruptures, and you can see the atheromas right there. This is basically where the monocytes are accumulating underneath the endothelial cells. These are amazing pictures, actually, and it shows you that this is what happens with high-fat diet or high LDL cholesterol. Now, as a physician, mostly you're looking into lipid profile. Most of the time, you will be ordering the lipid profile to assess the risk of atherogenesis. And you do have, if you order the lipid profile, you get the total cholesterol, LDL cholesterol, HDL cholesterol, triglycerides. We do need to retain desirable concentration of total cholesterol of less than 200, LDL cholesterol less than 130, HDL more than 40 milligram per deciliter, and then triglycerides less than 250. These are the desirable concentrations. And if you have concentrations other than these ones, then you are at high risk of developing atherosclerosis. We did describe the benefit of elevating HDL. How can we increase HDL in circulation? There are a few things that you could do. Do you think changing diet would increase HDL? Do you think statins, we know what statins are, right? Do you think statins increase HDL? They decrease LDL. They were excited about one of the statins just because it increased HDL by 5%. The company was so ecstatic about it. How do we increase HDL? Exercise. But also, I'm not advocating drinking, basically red wine drinking. But the way I always argue about this, fine. The vessels are good, clear, but your liver is being damaged. That's how I look at it. But also we can take the benefit of that by taking what? Resveratrol. Have you heard about resveratrol? This is the active ingredients in red grapes. And actually it's a hot item right now in terms of supplements because it's anti-aging. And resveratrol, this is the company that it induces sirtuin-1, which is anti-aging protein. And the company got sold for $800 million to GSK. This is the guy who discovered SIRT1, but you can order this resveratrol tablets, and it does increase your HDL without known mechanism. But this is one of the way, because they're saying drinking and so on. So why can't we take the active ingredient and the one that will increase HDL from the red grade and just basically take it? You do need to increase HDL above than 50 milligram if you could. And we talked about the CETP inhibitors are being tested currently. Alcohol and lipids, we talked about alcohol. And we said that low level of alcohol consumption, it's a fact. I'm not advocating drinking, but I'm just mentioning fact that they are advising people in the Western society to take a glass of wine, red wine, every day. But I keep saying that this would eventually kill your liver. So what's the point of having your HDL levels high? Then two things quickly, which we already covered: acute pancreatitis and hypertriglyceridemia. There's association between the two. If you have hypertriglyceridemia, you are at high risk of developing acute pancreatitis. This is basically cause number 3 in order after following the gallstones and alcohol that could induce acute pancreatitis. And finally, we do have, I think this is the last one, yeah, the alcoholic fatty liver disease. So basically, if you have high fat, high lipoproteins, and so on, this would lead to what? Cirrhosis, and sometimes it could lead to hepatocellular carcinoma and death. But also, the alcoholic fatty liver disease has been associated with several cardiovascular risk factors, such as obesity, lipidemias, hyperglycemia, hypertension, and smoking. In the non-alcoholic fatty liver disease, this lipidemia is usually characterized by the elevated triglyceride and LDL cholesterol levels. And also it is basically it gives, it has high risk, increased high risk for both liver and cardiovascular diseases and so on. Any question? Sorry, it took me some time. Then I spoke. Is what? Fasting, HDL? Well, the diet is not really going to change that HDL level that much. I mean, if you change the diet. So even if you're fasting, some people claim, yes, there is some, but it's not really strong, solid studies.
I recall last year, there was a statement in the presentation that says, when we're measuring cholesterol levels, we usually take it in a fasting person.
Yes, why do we take fasting blood sample? Because it's simple. You want to get rid of the chylomicrons. Because chylomicrons normally, they're absent in fasting sample. So the chylomicrons, if you look into actually the table, just want to show you this table. I didn't cover that. Plasma appearance, look into chylomicrons increase in 1 and 5. Milky. That milky sample will interfere with the assay. So that's why when we take fasting, we basically took the chylomicrons out, unless you see that even if it's a fasting sample, it's milky, that indicates what? Then you have a condition associated with hyperchylomicronemia. And what do? You just leave the sample sitting in the cold for a couple hours and you see the chylomicrons precipitating basically. But that's why we take fasting blood sample for lipid profile. Any other question?
Doctor, they do a blood test. They only measure the LDL and HDL, right?
They measure the cholesterol and the LDL, cholesterol, HDL, triglycerides, and total cholesterol.
But they don't measure the person's VLD and
Yeah, well, it's all because of the assay. I wish I had more time. I would have showed you how do we measure it, because we're using antibodies to separate. I mean, we used to do it by electrophoresis. That used to take 2 hours. Now we precipitate. Okay, all LDL. How? By using an antibody, for instance. to precipitate certain apoproteins. So you want to measure the LDL. What's the best one to measure LDL? Antibody. What's in the LDL? We said what protein? 100, right? So if I precipitate with APO 400, what do I get? I get the rest staying in the plasma. That's when I measure the cholesterol. So depending on which apolipoprotein you target, you could measure HDL or LDL.
No, I mean the IPN and ESDL.
We don't usually measure it because, as I said, limited. I mean, we could do it with electrophoresis. And I had a slide actually for electrophoretic pattern for lipids, but we don't do electrophoresis now for lipid profile. It's just time consuming. So the question is that, is it significant? If it's needed, we could send it to a reference lab that would do it for you. But for routine lab testing, we only measure HDL, LDL, total cholesterol, and triglycerides. If you notice, it's the same method for cholesterol measurements. But what's the difference? You could knock down certain lipoproteins, leave the rest, and you can measure the activity. So for total cholesterol, you don't knock down any of these lipoproteins. You just measure the cholesterol content in the plasma. You see what I'm saying?
Yeah.
Any other question? This one? Which one? These are the composition. This is lipoproteins. And this is Fredrickson. This one? Yeah, just take, I mean, I don't want you to memorize everything, but at least the endocrine related conditions, at least for this block. Ideally, you would remember all this because, as I said, these are all secondary conditions that will lead to dyslipidemias. So as a physician, if you have someone with hypothyroidism, or you have, or he's taking different drugs, you can see that depending on the drug he's taking, could affect his lipid profile. So I know it's too early for you, but as I said, hopefully by the time you graduate, all these conditions, you already remembered it. But for me, at least take the conditions, endocrine related conditions, and how they change the lipid profile. Okay? Any other questions? Thank you. It's good to see you again. Let me just close.